Practice Bulletin 107 is referring to induction of labor. So to start off, the summary recommendations include that inductions under 28 weeks of a gestation should be started with vaginal misoprostol. In general, the dosing for misoprostol should be 25 micrograms for the initial dose, and this can be redosed every 3 to 6 hours. And the Practice Bulletin even says that it's safe with pre-labor rupture of membranes. Another thing that they say is low or high dose PIT regimens are okay for patients. The B-level recommendation of data is that 50 micrograms of vaginal meso may be appropriate, although this higher dose is associated with uterine tachysystole. The next part of the paper talks about cervical ripening. So first off, they look at the Bishop score, which is shown right here, and this assesses whether the cervix is unfavorable. A score of 6 or less is unfavorable. The cervical ripening agents include prostaglandins as well as mechanical, which would be Foley balloon and osmotic dilators. For misoprostol, which is PGE1, this is dosed at 25 micrograms and redosed every 3 to 6 hours. For dinoprostone, there's either the gel or the vaginal insert, where the gel is 0.5 milligrams in 2.5 milliliters, and the vaginal insert is 10 milligrams with an infusion rate of 0.3 milligrams every hour. The patient should lie recumbent for 30 minutes, and the fetus should be monitored for at least 30 minutes up to 2 hours, and continued monitored if there are persistent regular uterine contraction of labor, part 2. This is going to focus on labor induction. The 4 main ways they talk about are oxytocin, amniotomy, membrane stripping, and nipple stim. For oxytocin, the uterus will respond after 3 to 5 minutes of initial administration, with steady state reached at 40 minutes. Uterus has receptors for oxytocin starting at 20 weeks of gestation, with a plateau at 34 weeks. Membrane stripping of note increases local concentrations of PGF2A. And lastly, for nipple stim, unilateral nipple stimulation has been associated with decreased risk of postpartum hemorrhage. The contraindications for an induction of labor are as follows: vasa or placenta previa, a transverse lie, cord prolapse, a prior classical cesarean section, active genital herpes, or a prior myomectomy with uterine cavity entry. And lastly, the notables from this entire practice bulletin include talking about uterine tachysystole. This is important to note because this is defined as 5 or more contractions in a 10-minute period averaged over a 30-minute window. Another thing they mention is that after sustained release dinoprostone, like the vaginal insert, people should wait 30 minutes until starting Pitocin. And lastly, the practice bulletin mentions that in pre-labor rupture of membranes, there is no evidence to suggest that there is an increased risk of infection with patients who have mechanical dilators or vaginal misoprostol. And that's the first part of induction of labor.